Hello, friends. Today is the 99th lecture, like 99 songs of A.R. Rahman. Today, I have come with a very, very important practical as well as theoretical topic, that is surgical management of postpartum hemorrhage. The topic gains the importance because the management of postpartum hemorrhage is so vital because it constitutes around 30 to 35% of maternal mortality, not only in India, throughout the world. So one must be well versed with both medical as well as surgical management of PPH. I think I have already talked about the medical management of PPH earlier. So today I will be talking on surgical management of PPH. This is a definite question in the exams. And in Dr. Padma Rao's words, PPH is a life savior, not only for the patients, but also for the students. If you answer PPH well, there's a good chance that you will be passed in the exam. But if you don't answer PPH well, it's a sure shot failure. So that's why every PG student should know everything about postpartum hemorrhage. Not only PGs, throughout our life, all of us should know how to manage a case of postpartum hemorrhage. So let's straight away jump into the topic with that much of introduction. I hope you have already understood the importance of the topic. How to decide on surgical management? Of course, we all know that the preliminaries are active management of third stage of labor, which includes number one, 10 units of oxytocin IM within 1 minute of delivery of the baby, right? This will also help in separation of placenta. I'm repeating, it is 10 units IM because usually in the OT after cesarean section, when we ask the anesthetist to give 10 units IM, they somehow feel it convenient to push 10 units in the IV. You know, the IV drip goes slowly and 10 units will go into the patient after, couple of hours or maybe even more than that. So it is 10 units IM, number one. Number two is controlled cord traction. Of course, there's a small controversy here. People say wait for the separation of placenta. Some people say don't have to wait for separation of placenta. It's immaterial. Whenever we give oxytocin, usually placental separation is hastened. It's always wiser to wait for the separation of placenta. Else there's a chance of, you without knowingly pulling down the fundus of the uterus and causing inversion that itself may cause postpartum hemorrhage. So I always want to be prudent and smart rather than go and argue with people. So it is better to wait for the signs of separation of placenta. Nothing is lost. Few more, let us say, seconds or couple of minutes only. So you all know the signs of separation of placenta. That is, there's a fresh gush of bleeding. There is a suprapubic bulge, and there is, the fresh contractions maybe. And then you can see that the placenta is almost coming in the vagina, apparent lengthening of the cord because of that. So that's the time to do the second step of the active management of third stage of labor, that is controlled cord traction. Now, the third step is actually a step which is needed to prevent postpartum hemorrhage, that is massaging of the uterus. So this step is not a part of routine management of active stage of third stage, but it is wiser to actually massage the uterus, especially in the multis when it is atonic. So these are the three steps. After that, of course, if there is still atonic PPH, we have got whole lot of drugs to manage that, starting from, again, starting or setting up a oxytocin drip where we can put in 20 units of oxytocin. We can also give ergometrin, which is now not a routine, but in a real postpartum hemorrhage, we can use ergometrin. And of course, every 3 minutes, we can, every 15 minutes, we can give that drug to a maximum of, let us say, 0.6 milligrams in that 1 minute. So, or we can also give the prostaglandin PGF2 alpha. So if you have exhausted that, of course, nowadays there is a mention about carbetocin. Carbetocin also is a very good long standing, and it's a long acting rather. And it doesn't have to be always kept in the fridge like oxytocin. So we have a whole lot of the medical management for postpartum hemorrhage, but it is only for the atonic uterus. So how do you decide on surgical management? After vaginal delivery, if bleeding continues despite well contracted and retracted uterus, see that is very important. Your oxytocin will only make the uterus contract and retract. But in spite of that, if there is bleeding, then you have to think beyond medical management and comes the surgical management. Look for extension of episiotomy. This is the usual thing. Suppose you have not given episiotomy, it may be perineal tears up to third-degree perineal tear. Perineal tears, of course, that is the next thing. And then, of course, vaginal lacerations, especially if you have used vacuum or forceps, or if the baby had been stuck for a long time in the second stage. Cervical tears, again, these are the ones which are usually missed because they are little deep inside. You have to nicely explore them. And of course, all these things should be explored thoroughly under proper light, maybe sometimes general anesthesia, and they have to be promptly sutured. So this is something like a first aid, first thing to be done. And we all know how to look for cervical tears. Cervical tear, you do a proper lighting and use two sponge holders and wandering method. That means you first apply maybe at 12 o'clock and let's say 2 o'clock position, check between them, remove the 12 o'clock, go to the 4 o'clock, check between 2 and 4, remove 2 o'clock, go to 6 o'clock, check between 4 and 6, like that. You keep on wandering, walking on the cervix, what we call it. And what is a cervical tear? Any tear that is actively bleeding, irrespective of the length, or a tear which is more than 2 centimeters. Both of them needs to be sutured. Vaginal laceration, again, you can make out. Sometimes even the extension of episiotomy, the angle will be very deep. Then you have to take the patient under general anesthesia. And you know how to suture that. Sometimes you may not get the peak or the apex. So you suture a little bit down only and then pull that, and then you will get the apex. Perineal tears, again, you have to explore properly and suture. So this is the first thing to be done. And then uterus is not responding to massage, your compression, tamponade, and whole lot of medical management. Then, of course, suspect inversion of uterus, right? So there is no response to this. So uterus is not palpable there. Either it could be flabby or it is not palpable because of the inversion. You can even think of morbidly adherent placenta, because placenta, in spite of your 10 units oxytocin IM, is not getting separated. There is no fresh gush of blood or there is no apparent lengthening of the cord. So you should suspect morbid adherent placenta. Nowadays, it is suspected before delivery itself or before labor by ultrasonologists. So they would tell us about morbidly adherent placenta. There are again 3 types. I don't want to go into the details of that. That's a chapter by itself. But suffice to say, the placenta that is trapped because it is separated but trapped. Other one is not trapped, but it is adherent. And in that simple adherent placenta or morbidly adherent placenta, in that you have accreta, increta, and percreta. Accreta is just adherent to the residua. Increta goes into the muscle, and percreta goes beyond the perimetrium of the uterus. So this has to be suspected. And finally, you should suspect uterine rupture. It is suspected because, see, in the previous slide, I said the uterus is well contracted and retracted. Then you suspect only the lower problems. Whereas here, uterus is not responding to the massage. So it is flabby, or your bimanual compression, or tamponade procedures, or medical measures. So these are 2 different slides. In the previous slide, you saw uterus is well contracted. In this slide, you see uterus is not contracted. And you will be thinking that let us give more and more oxytocins. But sometimes these are the problems you have to suspect: inversion of uterus, morbidly adherent placenta, and uterine rupture. So inversion of uterus, let us take up now. Johnson's management of inversion is the most popular management. So discovered as it happens and without appreciable shock. This method is done when you see that as you're watching the inversion is happening, and patient is not yet gone into so much of postpartum hemorrhage as to push her into shock, this management will be easy. Immediate replacement by pushing it back. Now, don't push it like this because you can't push the last thing that came, that is the fundus. You have to actually push the first thing that came out, right? So patient, if it is in shock, resuscitation followed by reduction under deep general anesthesia. The first one is reduction immediately in the labor room itself because patient is not in shock. So you have to slowly reduce the thing. The first thing that comes out is, lower portion of the uterus that has to be reduced first. And as you reduce halfway through, the fundus will go back automatically. So that is what is the immediate reduction. Whereas if the patient has gone into shock, you can't handle that patient in the labor room. You have to wheel the patient into the OT, and there under deep general anesthesia, you have to do it. I'm using the word deep general anesthesia. As you can see here, the fundus is not pushed because you will be just playing like a boxing. The whatever came first has to be reduced, and finally the fundus will go back, and put your hand inside for some time and then start oxytocin, and then only you have to remove the hand. Otherwise, it will come back again. The other tougher management of surgical management of inversion is that here, as you can see from the upper side, that is from the laparotomy side, the fundus has gone so much, it has even dragged inside the ovaries, and you can only see the fimbria here. As you can see, this is the laparoscopic or laparotomy view. This is actually laparotomy view. As you can see, there is an incision on the abdominal wall. So this is necessitated only when you feel that the patient, you cannot feel the fundus of the uterus by ultrasound at all, and everything is outside. The doubt for patients is for the doctors is that whether to remove the placenta first and then reduce it, or whether not to remove the placenta. It is advised not to remove the placenta. You know why? If you remove because it is tempting to remove the placenta when everything is outside. It is tempting to remove the placenta, but you should not remove the placenta, because if you remove the placenta, the atonic PPH will be so severe, you will never be able to do anything. Plus, the open sinuses will suck in the air, and there can be air embolism. So leave behind the placenta, reduce the inversion, and then slowly go for controlled contraction. So Huntington's method is one where pull the fundus using clamps or alleys from the cup of the inversion. This is easier said than done. It's extremely difficult. Sometimes you may have to ask your assistant to push the fundus from below using a gauze on the sponge holder, or sometimes even with the fist of your hand, gloved hand. Push the fundus from vagina. That's what I was trying to tell. Halton's method on the other side is incise the tight rim. See, this is the rim. This is the rim. So if you apply Alice here and try to pull as in Huntington's method, it may be difficult. So you just make a nick here, so an incision here, and put your finger inside and push the cervix from the posterior portion. Rest is as above, okay? So close the posterior incision, this incision what you have made, but you should be aware that this will be a weaker spot. Should she have next pregnancy, there will be chances of rupture here, because you are putting almost like a classical incision on the fundus, that too, or on the at least the posterior wall of the uterus. So this patient definitely requires cesarean section in case she becomes pregnant next time. You should remember that. So silastic vacuum cup also is being used nowadays because from the above at laparotomy for the correction of the acute inversion. So you put a vacuum cup here and hope that it will suck in all the fundus. It is again easier to talk here on the slide, but maybe extremely difficult. People are very innovative. Laparoscopy guided correction. So instead of opening up like this, if you have to simply pull up the fundus or the walls of the uterus, you can do it through a laparoscopy as well and slowly try to pull up. And even if you have to do an incision here, so you make an incision and try to grab up. So it's all very easy to say, but it's very difficult. One should not actually land up with these problems only. Very rarely hysterectomy as a last resort. If your patient is bleeding so heavily and you feel that saving her life is more important than saving the uterus, and especially if she is a multi, then it is better to go for hysterectomy. Again, hysterectomy is not going to be easy here because the steps of hysterectomy is round ligament first and infundibulopelvic ligament. Where is the round ligament here? Where is the infundibulopelvic ligament here? So it's easier to say things, but it's very difficult to do things. But somehow we are in a desperate situation there. We have to do things which are possible to do, right? Morbidly adherent placenta. Now, this is another situation which is very, very tough for us to manage. So how do you manage? Quickly confirm by ultrasound in the labor room. Nowadays, most of the labor rooms have ultrasound machine. In fact, I'm sure all the nursing homes or all the hospitals have this right now. Manipal, we are having luxury. We have two ultrasound machines in the labor room. Simple adherent placenta. This is the most suitable case for MRP, that is manual removal of placenta under deep general anesthesia. I'm using the word deep general anesthesia. You have to ask the anesthetist to give deep general anesthesia. Halothane is the one which they give at the time of insertion of our hand into the uterus. So I don't go to the procedure of simple adherent placenta removal MRP. It's very simple. You have to hold the cord as a guide. Go along with the cord. This is a tricky question asked in the exam. How do you know you are entering the uterine cavity? Sometimes, you may enter through the posterior fornix into the abdominal wall. Everything is soft. Patient is under anesthesia. You won't realize. That's why it's always to, leave behind the cord. Don't pull the cord so badly that it will snap and then you don't have any guidance. If you have the cord, that is always good. So go along the cord. The cord will guide you into the uterine cavity. And once you go into the uterine cavity, always better to go. Suppose the placenta is posterior, the supinated hand goes like this. Okay, if suppose the placenta is like this, then of course you go to the supinated hand only, but you come from above and remove the placenta, right? So some people say if it is anterior, you can go the pronated hand like this. You can go with the pronated hand, go from the below and come. So if you are used to supinated hand, remember posterior placenta, if the placenta is posterior like this, you go this way and get the placenta. But if it is like this, anterior wall like this. So you can, if you go supinated hand, you have to come like this. But it is always better to go to the pronated hand and come like this. So anyway, this supinated hand, pronated hand is easier for me to talk. But at that desperate situation, you will simply put the hand inside and try to grab the placenta and remove it. Now, akrita is hysterectomy followed by removal as much as possible. Rarely have to remove a portion of the myometrium along with the, not hysterectomy, hysterotomy, sorry, along with the placental cotyledons. Well, this akrita is something gone little deeper than the decidual layer. So you may have to just put a incision on the uterus and you have to remove all of them. If it is at cesarean section, already incision is there. Some people believe in removing a portion of myometrium. Suppose the placenta is so badly adherent, you will, but this uterus is going to be very dangerous uterus for the next pregnancy. It may rupture even in the antenatal period. That has to be explained to the patient, written in the notes completely. If it is so, after simple adherent placenta and akrita, we go to incrita and percrita. Incrita means it has gone into the myometrium, and percrita means it has gone beyond the myometrium, beyond the perimetrium also. Here, there is absolutely no doubt as to how to manage it. If you have just come across it as a surprise at the cesarean section or at the normal delivery, you have to go for emergency hysterectomy. But in modern obstetrics, we can diagnose this much earlier in the antenatal period. So an elective cesarean hysterectomy or planned hysterectomy is always better. And usually it is done at 36 to 37 weeks. That is the ideal time to do a planned elective cesarean followed by hysterectomy. So here, of course, the planned elective cesarean section will be somewhat like a classical cesarean section. You don't even have to suture back the classical scar. you can just put the towel clips and you can straight away proceed with the emergency hysterectomy, which I'm going to talk in detail little later. Uterine rupture, of course, this is a calamity that occurs when you leave the patient for vaginal delivery after a previous cesarean section, or sometimes after a previous myomectomy scar, or any scar for that matter, or in a case of obstructed labor, neglected obstructed labor. So in this situation, the only choice or only solution for us is peripartum hysterectomy. So be prepared for this all the time. Peripartum hysterectomy has got different angles for it. I have explained it nicely in a peripartum hysterectomy talk, but today I would just summarize it. That is, tertiary care center is the place where it has to be done with an experienced obstetrician in place and with backup of senior anesthetist, urologist, vascular surgeon, and plenty of blood and blood products to the blood bank, and ICU facilities should the patient be shifted to that after the cesarean hysterectomy or the peripartum hysterectomy. Counseling is very, very important because hysterectomy means the patient is going to lose the uterus permanently, but the counseling this time may be slightly difficult in an emergency situation because patient may be in shock. You are trying to save the patient. You have to explain to the patient party, especially the husband and the others. Or if the patient is taken up for a planned peripartum hysterectomy, then again, you have to explain to the patient herself. So the decision is always a shared decision, as I have always been telling. And in addition to the decision on hysterectomy, you have to counsel the patient for need of ICU as well as future fertility. Of course, it goes without saying there should be an informed consent by the patient only if the patient is anesthetized completely or if the patient is in total deep shock. In order to save the patient, you may have to do hysterectomy without the patient's her own consent, but a consent from the closest relative should be always taken. So these are the things which have to be done simultaneously, not, there's no time to waste. CBC, coagulation profile and cultures. Massive transfusion protocol is alerted. We have the facility in Manipal. I'm sure other places, other big hospitals have this, what is called MTP protocol, that is massive transfusion protocol. Central line and 2 large bore IV lines should be in place. Catheterization, better is urethral 3-way catheter and maybe sometimes ureteric catheter also. I put a question mark there. Action items that will be needed in the event of emergency hysterectomy should be always there. Most of the hospitals have a hysterectomy set ready. The key principles or the deviations from the usual gynec hysterectomy are: number 1 is in emergency with an unstable patient, clamping the uterine blood vessels takes precedence over adhesiolysis or packing and cleaning. So if the patient is almost sinking and it is unstable, you straight away start clamping the uterine blood supply, and then you can go for adhesiolysis, packing the abdomen, cleaning, and all those things. Pedicles can be rapidly clamped, cut, and dropped. I repeat, clamp, cut, and drop. This is the procedure to be sutured later. So the precedence is just clamping all the different, the pedicles and remove the uterus and hand over. Then leisurely you can suture the pedicles. Clamp, cut, and drop. I'm highlighting it so that it is remaining in your mind. This is the principle of emergency hysterectomy, usually peripartum emergency hysterectomy. Clamp, cut, and drop, CCD. When the patient is hemodynamically stable, however, obtaining adequate exposure and uterine traction will minimize vascular or ureteral injury. And of course, if the bladder can be easily pushed down, sharp dissection is preferred or urologist help is sought. This goes without saying, especially in a previous cesarean section which has gone for rupture uterus or if it is adherent placenta because of previous scar adherence. Every attempt should be made to identify the ureter time to time, avoid ligating it. Of course, sometimes if you're too much uretrophobic, then you may go and clamp the ureter itself. That is jokingly told by many gynecologists. But you should be aware that you should not be disturbing the ureters. Adherent placenta should be left in place as removal can increase the total. That's what I said. Once you deliver the baby, you don't go for removal of placenta. It is unnecessary because it will go away with the uterus anyway. And there is no need to even suture the anterior incision of the uterus unless it is heavily bleeding. Just put towel clips and quickly clamp. After all, we have to clamp only 3 pedicles, right? One is the round ligament, second one is infundibulum pelvic ligament, or either actually now since we are retaining the ovaries here, we don't go for infundibulum pelvic ligament also. We just go for the ovarian ligaments. And then, of course, the other major one is the uterine artery. Then, of course, the angles lower down. So we have to quickly do this procedure. So some people use tourniquet if they want to, go above the level of cervix. But it is always better to go for total hysterectomy, however difficult it is, especially after cesarean or after late second stage. The cervix is so thinned out, you won't know the lower portion. There are techniques to do that. I will explain that. Rubber catheter tourniquet at the level cervix temporarily shuts off flow through the uterine vessels. It prevents massive bleeding from the accreted placenta. This is done before. Okay. Hysterectomy, the general principle, no special technique as such, same steps as gynecological hysterectomy, I told you, should be simple enough to perform rapidly. Leave as minimal dead space as raw surface as possible, especially in coexistent coagulopathy, right? And clamps operate very close to the uterus. If you go too far, then you'll be unnecessarily clamping the ureters and important structures. Don't include excessive tissues because the tissues are stretched, they are broad. Don't include. Just be close to the uterus as possible. The ligaments and vessels held by 3 clamps, 2 lateral and 1 medial. I can show this way. Keep sufficient stumps. So 2 lateral and 1 medial. Double ligation, simple and transfixed. So twice you have to ligate because these are all dilated vessels or thick pedicles. So you have to be very careful. So this is one of the cases what we have done hysterectomy for. As you can see, it's a nicely increta placenta. So we have removed the uterus along with the placenta, So atonic PPH management, stepwise devascularization of the uterus. See, you have already tried the drugs or you can't do much about that anymore, especially at the cesarean section. You would have asked the anesthetist to give 10 units of oxytocin IM, but still there is bleeding. So here, at least you are directly exposed to the uterus. And because after the laparotomy, you can do these steps very easily. It is called stepwise devascularization of the uterus. Or you can go for the compression sutures. There are a whole lot of compression sutures I'm going to talk. Internal iliac ligation. This nowadays, our some of the gynecologists have mastered them. Otherwise, you can always take the help of a vascular surgeon or a cardiothoracic surgeon. Hysterectomy, of course, is the last resort for atonic PPH. Stepwise devascularization, as you can see here, you start with the unilateral or bilateral uterine artery ligation at the upper part of the lower segment. So this is how you can start off with this upper part of the lower segment. And then bilateral uterine artery ligation. And of course, low uterine artery ligation to include the cervico-vaginal branches and vaginal arteries. So these are the lower ones that you can also ligate after pushing the bladder down and avoiding the ureteric injury. So this is the stepwise devascularization. Unilateral ovarian vessel ligation near to the utero-ovarian anastomosis also can be done. Bilateral ovarian vessel ligation. See, all the procedures can be unilateral or bilateral. So it depends upon how much bleeding is happening. Uterine artery ligation is effective in 90%. Why we go for unilateral? Because at least to keep one ovary healthy. Sometimes when you tie this ovarian, supply is hampered. But we are so lucky that whatever you ligate, there will be always some collaterals that will supply the uterus as well as the ovaries. But still, if you can manage with unilateral ligation, it is always preferred. Compression sutures, there are a whole lot of lectures on this. I will just summarize in one slide. Beeline sutures, as you can see here, It involves pair of vertical sutures brace, like put suspenders sutures opposed at the anterior and posterior walls of the uterus. Thus, it works by tamponade to control the hemorrhage. I sometimes question this because once the uterus starts contracting, these sutures become a little bit looser. But anyway, at that particular moment, you will be able to manage this. As you can see, you go from outside, go all the way to the other side, and then come and go take inside, again go backwards and come again in front and come out of this place and suture this. So once you suture this, you can only see that very nicely put the braces. So uterine incision is of course needed here. Anyway, if you have done a cesarean section, that incision is always exists because you have to go inside, then come outside, and then inside, so outside, and from outside to inside, again come outside. So that's why uterine incision is required. Heyman or Arul Kumaran. So this is like a modified Belin sutures. Even if you have not opened the uterus, you can simply put two sutures like this, longitudinal sutures. Because why longitudinal sutures? All the spiral arteries, arcuate arteries go like this. If you suture them like this, they will be tightened. If you suture transversely, you may miss the arteries altogether. So it's always a vertical sutures. Simple vertical sutures, no uterine incision is required here. Needle pass from anterior wall to posterior wall above the bladder reflection. So very simple. If you want, you can put additional transverse sutures at the isthmocervical junction. This is to, the arteries which go up to ligate those arteries, transverse sutures. These are the ones. These are the ones. Right? Cho suture, he felt, you have to be slightly different. And their group made the anterior wall into cavities, come out from the posterior wall. These are like box sutures, 2 to 3 centimeter lateral above and below, making a squares. So easy to perform. You just put multiple sutures, but these are all like temporary ones, right? Sandwich technique is another technique, compression sutures plus balloon tamponade. So from inside, you put a balloon tamponade, and from outside, you put a suture. Just like a sandwich. Who is getting sandwiched in between? The uterine wall, between the suture and the balloon. Belin suture is the only one that does not occlude the uterine cavity and hence can be used in combination with an intrauterine balloon. Where Cho suture, Sindol, or even the Arul Kumaran suture, they'll go through and through. Whereas here, you are not going actually into the cavity and compressing it. So balloon tamponade plus compression suture is possible with Belin sutures. The sequence will be insert the Belin sutures techniques as usual. Insert the balloon and fill it with 100 ml of fluid. Close the uterine incision, taking care not to burst the balloon, and tie off the Belin sutures later. Again, while tying the Belin suture, if you are too tight, the balloon will burst. Of course, the balloon is not simple balloon like what we use for the birthday parties. It's a little tougher balloon only. But these are all, again, temporary methods, I feel, because, ultimately, the definitive method that you have to adopt in a tertiary care center is slightly different. But luckily, in the meanwhile, if the uterus contracts, responds, sometimes uterus contracts later. If there was hypoxia, it may not respond to the drugs. If there was infection, it may not respond to the drugs. But once the hypoxia is overcome, once the infection is sort of tackled by the IV antibiotics, the uterus may slowly start responding and it may contract. At that time, of course, you don't have to do hysterectomy. But otherwise, according to me, all these balloon tamponade or other sutures, surgical techniques, ultimately may land up in hysterectomy to save the patient. That's the only definite thing. The only other thing that we can do is the internal iliac ligation. Again, one has to make themselves expert in this. It's not very easy, especially when the uterus is there disturbing you. Even I have seen the vascular surgeons being little uncomfortable in the pelvic area to do this internal iliac ligation. But our seniors, our professors, some of my own colleagues, my juniors, have made themselves an experts on this internal iliac ligation. But internal iliac ligation sometimes may not work. Ultimately, you may land up with hysterectomy. Most of the patients that we have come across in Manipal, they have been referred to us after all these things have been tried. So to save the patient, ultimately, you may have to do a hysterectomy only. So that is again peripartum hysterectomy, clamp and drop technique, double ligatures for all pedicles, to total hysterectomy whenever possible. I told you that because the descending cervical branches or vaginal branches will keep on bleeding, and cervix doesn't contract that well. So it is always better to go for total hysterectomy. Take care descending cervical and vaginal arteries otherwise. Thank you very much for the details of peripartum hysterectomy. Go back to my lecture on peripartum hysterectomy.